Here are the next 20 questions and answers. 386. What diseases are associated with a low SAG, 1.1 GDL? Infections, except spontaneous bacterial peritonitis. Cancer and nephrotic syndrome are associated with a low SAG. 387. What conditions are associated with a high SAG, 1.1 GDL? A high SAG suggests portal hypertension, as seen in cirrhosis, heart failure, and hepatic vein thrombosis. 388. What is spontaneous bacterial peritonitis, SBP? SBP is a bacterial infection of the acidic fluid without a bowel perforation, most often caused by E. coli. 389. How do we diagnose SBP? The best initial test is a cell count showing 250 neutrophils in the acidic fluid. 390. What is the treatment for SBP? SBP is treated with antibiotics like cefotaxime or ceftriaxone. 391. How is SBP prevented from recurring? Patients with SBP need lifelong antibiotic prophylaxis, usually with norfloxacin or TMP-SMX. 392. How are ascites in edema treated in cirrhosis? Ascites in edema are treated with diuretics like spironolactone, and large volume ascites may require paracentesis. 393. How are coagulopathy and thrombocytopenia managed in cirrhosis? Coagulopathy and thrombocytopenia are treated with fresh frozen plasma and platelets if bleeding occurs. 394. How is hepatic encephalopathy treated in cirrhosis? Hepatic encephalopathy is treated with lactulose and rifaximin. 395. What is the treatment for hypoalbuminemia in cirrhosis? There is no specific therapy for hypoalbuminemia in cirrhosis. 396. How are spider angiomata and palmar erythema treated in cirrhosis? There is no specific therapy, as these are just signs of liver disease. 397. How are varices managed in cirrhosis? Varices are treated with propranolol and endoscopic banding. 398. What is the treatment for hepatorenal syndrome in cirrhosis? Somatostatin, octreotide, and midodrine are used to treat hepatorenal syndrome. 399. How is hepatopulmonary syndrome treated in cirrhosis? There is no specific therapy for hepatopulmonary syndrome. 400. What are the common symptoms of acute alcoholic hepatitis? Symptoms include jaundice, anorexia, weight loss, and right upper quadrant pain. Here are the next 20 questions and answers. 401. What signs can be found on examination of a patient with acute alcoholic hepatitis? On exam, you may find ascites, liver tenderness, and fever. 402. What lab results are typically seen in acute alcoholic hepatitis? Common findings include AST-ALT, elevated GGTP, bilirubin, INR, and PT. 403. What is the mortality rate for severe alcoholic hepatitis? Severe alcoholic hepatitis has a 50% mortality rate. 404. How do you exclude viral and drug-induced hepatitis in diagnosing acute alcoholic hepatitis? Clinical evaluation and specific tests for viruses or drugs that can cause liver injury. 405. What is the discriminant factor and how does it guide treatment in acute alcoholic hepatitis? The discriminant factor formula determines if steroids should be used for severe cases. 406. What is hepatopulmonary syndrome? Hepatopulmonary syndrome is a lung disease caused by liver failure, leading to hypoxia. 407. What is orthodeoxia in hepatopulmonary syndrome? Orthodeoxia is when hypoxia occurs specifically upon sitting up or standing. 408. How is hepatopulmonary syndrome treated? There is no specific therapy, and liver transplant is the main treatment option. 409. What is alcoholic liver disease, and how is it diagnosed? Alcoholic liver disease is diagnosed by excluding other causes and may require a liver biopsy. 410. How does alcohol affect liver enzymes, AST and ALT? In alcoholic liver disease, AST is higher than ALT, unlike viral hepatitis. 401. What happens to liver enzymes after binge drinking? Binge drinking causes a sudden rise in GGTP, a liver enzyme. 412. What is primary biliary cholangitis, PBC? PBC is a liver disease involving destruction of bile ducts, leading to cirrhosis. 413. How do you diagnose primary biliary cholangitis? PBC is diagnosed by positive anti-mitochondrial antibody, AMA, test and liver biopsy. 414. What are some unique features of PBC? Unique features include xanthelasma, xanthomas, and osteoporosis. 415. How do you treat primary biliary cholangitis? Treatment includes ursodeoxycholic acid and obeticholic acid to improve bile flow. 416. What is primary sclerosing cholangitis, PSC? PSC is a liver disease characterized by inflammation and scarring of the bile ducts. 417. How is PSC related to inflammatory bowel disease, IBD? Over 80% of PSC cases occur in people with IBD, especially ulcerative colitis. 418. What are the common symptoms of PSC? Symptoms include pruritus, elevated alkaline phosphatase, GGTP, and elevated bilirubin. 419. How does early PSC compare to primary biliary cholangitis, PBC? Early PSC can resemble PBC, but bilirubin may be normal in early PSC. 420. What is the most accurate diagnostic test for PSC, MRCP or ERCP, which show narrowing, beading, or strictures in the bile ducts? 421. How is PSC treated? PSC is treated with medications like cholestyramine or ursodeoxycholic acid. 422. Does PSC improve if the associated IBD resolves? No, PSC does not improve even if the IBD is treated or the colon is removed. 423. What makes PSC different from other causes of cirrhosis regarding diagnosis? PSC is the only cause of cirrhosis where biopsy is not the most accurate test. 424. What is alpha-1 antitrypsin deficiency? It's a genetic condition causing liver disease and emphysema due to a shortage of alpha-1 antitrypsin. 425. How is alpha-1 antitrypsin deficiency diagnosed? By identifying liver disease, emphysema, and a family history of COPD in young non-smokers. 426. How is alpha-1 antitrypsin deficiency treated? By replacing the missing enzyme, alpha-1 antitrypsin. 427. What is hemochromatosis? Hemochromatosis is a genetic disorder causing excessive iron absorption and organ damage. 428. What genetic mutation causes hemochromatosis? Hemochromatosis is caused by a mutation in the C2A2Y gene. 429. Why do men develop hemochromatosis earlier than women? Men develop it earlier because menstruation helps women lose iron and delay onset. 430. How is hemochromatosis detected? By finding mildly abnormal liver tests and elevated iron levels in the blood. 431. What are the common symptoms of hemochromatosis? Symptoms include fatigue, joint pain, skin darkening, diabetes, and heart disease. 432. What infections are people with hemochromatosis more susceptible to? Infections from iron-feeding bacteria like Vibrio, Yersinia, and Listeria. 433. What is the most accurate test for diagnosing hemochromatosis? A liver biopsy, which can confirm excess iron deposition. 434. What heart issues are seen in hemochromatosis? Conduction defects and dilated or restrictive cardiomyopathy. 435. How can MRI help diagnose hemochromatosis? MRI can detect increased iron deposition in the liver. 436. What does an abnormal MRI and genetic test indicate in hemochromatosis? It can avoid the need for a liver biopsy. 437. Can glucose levels confirm a diagnosis of hemochromatosis? No, glucose levels alone cannot confirm the diagnosis. 438. What is the role of Prussian blue stain in diagnosing hemochromatosis? It helps detect iron in blood cells, useful for diagnosing sideroblastic anemia. 439. What is iron chelation therapy used for in hemochromatosis? For patients who cannot be managed with phlebotomy or have anemia from overtransfusion. 440. What are some examples of iron chelation drugs? Deferoxamine, Deferasirox, and Deferiprone. 441. What is the preferred treatment for iron overabsorption in hemochromatosis? Phlebotomy, blood removal, is the best therapy. 442. Can liver fibrosis resolve with treatment in hemochromatosis? Yes, if phlebotomy is started before cirrhosis develops. 443. What is the relationship between chronic hepatitis B and cirrhosis? Both chronic hepatitis B and C can lead to cirrhosis and increase liver cancer risk. 444. Can physical findings alone diagnose chronic hepatitis B or C? No, blood tests are needed, as physical findings are not specific. 445. What test is used to measure hepatitis B activity? The hepatitis B DNA level by PCR is the most accurate test. 446. Is liver biopsy important in chronic hepatitis B? No, biopsy is no longer necessary to detect bridging necrosis in chronic hepatitis B. 447. How is chronic hepatitis C diagnosed? By a hepatitis C-PCR RNA viral load test, as acute infection is often asymptomatic. 448. Why is liver biopsy done in chronic hepatitis C? To determine the level of inflammation and fibrosis to guide treatment. 449. What are the treatment options for chronic hepatitis B? Medications include idefovir, lamivudine, telbivudine, entecavir, tenofovir, and interferon. 450. Is combination therapy more effective than monotherapy in chronic hepatitis B? No. Combination therapy has not been shown to be more effective than monotherapy. 451. Who should be tested for hepatitis C? Everyone born between 1945 and 1965 should be tested, even without symptoms. 452. What are the main treatments for chronic hepatitis C? Oral medications like sofosbuvir velpatasvir, ledipasvir sofosbuvir, and elbasvir grazoprevir. 453. What is the most common treatment for genotype 1 hepatitis C? Ledipasvir and sofosbuvir taken orally. 454. What is the cure rate for hepatitis C with these treatments? Over 95% of patients achieve a cure with a 12-week oral therapy course. 455. How do we assess if the hepatitis C treatment was successful? By showing a suppressed viral load at 12 and 24 weeks after therapy. 456. What is the most important factor in predicting the response to hepatitis C treatment? The genotype of the hepatitis C virus. 457. What determines whether hepatitis C treatment has been effective? The PCR RNA viral load, not liver function tests. 458. What is the role of a liver biopsy in diagnosing hepatitis C? A liver biopsy helps assess the extent of liver damage. 459. What are the side effects of interferon used in hepatitis C treatment? Interferon can cause arthralgias, thrombocytopenia, depression, and leukopenia. 460. What is the main side effect associated with ribavirin? Anemia, due to ribavirin's effect on red blood cells. 461. What side effect is linked to adefovir in hepatitis C treatment? Adefovir can cause renal dysfunction. 462. Does lamivudine have any significant side effects? Lamivudine is generally well tolerated with few side effects. 463. What is Wilson disease? Wilson disease is a genetic disorder causing copper buildup in organs. 464. What causes copper to build up in Wilson disease? A deficiency in ceruloplasmin, the protein that helps excrete copper. 465. Which organs are affected by copper buildup in Wilson disease? The liver, kidneys, red blood cells, and nervous system. 466. How does Wilson disease impact the liver? It can lead to cirrhosis due to copper-induced liver damage. 467. What is the most likely diagnosis if a patient has neurological symptoms like psychosis, tremor, and ataxia, along with Coombs negative hemolytic anemia? The most likely diagnosis is Wilson disease. 468. How is Wilson disease different from liver failure in terms of neurological symptoms? Wilson disease causes psychosis, unlike the encephalopathy seen in general liver failure. 469. What diagnostic test is the best initial test for Wilson disease? A slit lamp examination to look for Kayser-Fleischer rings. 470. What is the significance of Kayser-Fleischer rings in diagnosing Wilson disease? They indicate copper buildup in the eye, which is characteristic of the condition. 471. What other test is used for diagnosing Wilson disease? A liver biopsy to detect increased hepatic copper. 472. What is the most accurate diagnostic test for Wilson disease? Measuring urinary copper excretion after giving penicillamine. 473. Is decreased ceruloplasmin a reliable diagnostic test for Wilson disease? No, it is not the most accurate test, even though ceruloplasmin is often low. 474. What is the treatment for Wilson disease? Penicillamine, which helps remove excess copper from the body. 475. What other medications can be used if a patient is allergic to penicillamine? Zinc or trientine can be used instead. 476. Who is most likely to have autoimmune hepatitis? Young women characterized by liver inflammation and positive ANA. 477. What specific tests are used to diagnose autoimmune hepatitis? Liver-kidney microsomal antibodies, anti-smooth muscle antibodies, and high IgG. 478. What is the most accurate diagnostic test for autoimmune hepatitis? A liver biopsy. 479. How is autoimmune hepatitis treated? With prednisone and/or azathioprine to suppress the immune system. 480. What are the two types of non-alcoholic fatty liver disease? NAFLD. Non-alcoholic fatty liver, NAFL, and non-alcoholic steatohepatitis, NASH. 481. What makes NASH different from NAFL? NASH involves inflammation, fibrosis, and potential progression to cirrhosis. 482. What are the common causes of NAFLD? Obesity, diabetes, hyperlipidemia, and corticosteroid use. 483. What is the most important issue when diagnosing NAFLD, excluding more serious liver diseases like viral or autoimmune hepatitis? 484. How is NAFLD treated? By correcting underlying causes like obesity and diabetes, but no specific drug therapy. 485. What is the MELD score and what does it predict? The MELD score predicts survival of patients with cirrhosis and alcoholic hepatitis. 486. What factors are used to calculate the MELD score? Age, creatinine, bilirubin, and INR. 487. How does the MELD score affect liver transplant prioritization? A higher MELD score means higher priority for liver transplant. 488. What does a high MELD score indicate about a patient's prognosis? A high MELD score indicates a poor prognosis and higher risk of early death. 489. What is focal nodular hyperplasia, FNH, and how is it identified? FNH is a benign liver lesion identified by central stellate scarring on imaging. 490. Do focal nodular hyperplasia lesions require treatment? No, FNH lesions do not require treatment. 491. What is a hemangioma and how is it typically found? A hemangioma is a benign liver lesion made of abnormal blood vessels, often found incidentally. 492. How is a hemangioma diagnosed? Hemangiomas are diagnosed using imaging tests like ultrasound CT or MRI. 493. What treatment is needed for hemangiomas? If small, 5 centimeters, no treatment is necessary. 494. What is a hepatic adenoma and how does it behave differently from FNH and hemangiomas? Hepatic adenomas are influenced by hormones and can grow, especially during pregnancy. 495. What is the risk associated with hepatic adenomas? Hepatic adenomas have a small risk of malignancy, unlike FNH and hemangiomas. 496. How is a hepatic adenoma diagnosed? A biopsy is the definitive diagnostic test for hepatic adenomas. 497. What is the key distinguishing feature of FNH on imaging? The presence of central stellate scarring. 498. What differentiates hepatic adenomas from FNH and hemangiomas in terms of hormonal influence? Hepatic adenomas grow in response to hormones, unlike FNH and hemangiomas. 499. How does focal nodular hyperplasia, FNH, compare to hemangiomas and hepatic adenomas? FNH has central scarring, is benign, and has no malignant potential, unlike the other two. 500. Why is it important for everyone with cirrhosis to get an ultrasound? To screen for liver cancer, as ultrasound is 95% sensitive at detecting it. 501. What is the characteristic feature seen on a biopsy for IgG4-related pancreatitis? Lymphocytic and plasma cell infiltrates. 502. Why is autoimmune pancreatitis often confused with pancreatic cancer? They can appear similar on imaging. 503. What are the symptoms of pancreatic cancer? Painless jaundice, weight loss, and a non-tender epigastric area.